Welcome to my episode. This episode is for amenorrhea. Amenorrhea is a symptom, not a disease. It is diagnosed by pathologically. Amenorrhea is a word from Greek. A mean no, meno mean menstruation, rhea mean flow. It means there is no menstruation. Failure of onset of menses by the age of 14 in the absence of secondary sexual character, or failure of onset of menses by the age of 16 in the presence or absence of secondary sexual character. Primary amenorrhea is due to either the cause. You remember in the last lectures we talked you need intact hypothalamic pituitary ovarian axis and intact genital tract, because if there is any defect in this line there will be amenorrhea, and if it happens before the menses occurs then it will lead to primary amenorrhea. Now I will give you the causes and we will talk in detail about the causes and their treatments. Amenorrhea may be physiological before menarche, pregnancy, lactation, post-menopause. When it is pathological, it can be primary amenorrhea. The prevalence of physiological is less than 0.1%. if it is not pathological. Secondary amenorrhea, the prevalence, if not physiological, 3 to 4%. What are the causes of primary amenorrhea? Either there is a delay in the menses due to primary amenorrhea, developmental defect of endocrine origin, androgen insensitivity syndrome, testicular feminization in males, pseudo-hermaphrodite, hypogonadotrophic hypogonadism. In this, there is damage to pituitary to hypothalamus. These are due to surgery, injury, trauma, infection, due to any radiation, for the treatment of cancer, genetic defects, high dose of long-term use of steroids or opioids, high prolactin level, severe stress. If you are in severe stress, it can lead to amenorrhea. Severe weight gain or weight loss, chronic inflammatory diseases, iron overload. Gonadotrophin deficiency due to pituitary or hypothalamic dysfunction, there is lack of hormones GnRH, FSH or LH. There are some conditions, these are acquired conditions and they can cause primary amenorrhea. In that we can include classical galactosemia, thalassemia and sickle cell disease, hyperprolactinemia, ovarian failure, polycystic ovarian syndrome, hyperandrogenism, thyroid dysfunction. In thyroid dysfunction, we will include hypothyroidism and tumor. Cervical stenosis and vaginal stenosis are rare and it will end up in cryptomenorrhea. Direct toxicity of galactose to oocyte and follicle, leading to accelerate atresia of the ovarian pool. Transfusion. In case of sickle cell or thalassemia, there will be iron overload. This will lead to gonad dysfunction, the absence of puberty development. There are some of the causes related to the chromosomal abnormality. It can be Turner syndrome, mosaic, XY, testicular feminization, Swyer syndrome. In Swyer syndrome, there is a genome is male but phenotype is female. It is a rare disorder by the failure of sex gonads. The testis of the ovary to develop, there is 46XY, the defect in SRY. Girls with Swivels syndrome, lack of sex gland, ovary, and instead of sex glands with the woman, they have gonadal streaks in which the ovary do not develop properly, aplasia, and they are replaced by functionless fibrosis tissue because they lack ovaries. Girls syndrome do not produce sex hormone, will not undergo puberty unless you treat them with hormone replacement therapy. Mutation is different genes are cause this syndrome. The condition can occur as a result of new mutation or can be inherited into a autosomal dominant, autosomal recessive, X-linked or Y-linked matter. They are either normal height or very tall, but they have infantile uterus. Now you can see androgen insensitivity syndrome and testicular feminization. As I told you, there is X-linked chromosomal disorder with genetic male which have XY and lack ARS. Classically, they can be complete, partial, or mixed. Due to insensitivity of androgen to secrete androgen, testes are present and secrete testosterone. They do not descend into from the body cavity. Anti-Mullerian factor present, and this cause internal Mullerian structure cannot develop. Wolffian structure also fails to develop because of insensitivity of testosterone. There is testis, there is no uterus, there is vagina, either it is very short or blind vaginal pouch is present. There is fusion of the labiosacrotal fusion, and they may present as ambiguous genitalia. In this picture, it is very clear and you can see the levels they can present. Either there is a small fusion, either it is very severe case. The other is Kalman syndrome. As we told, there is a problem in the hypothalamus. The patient will come to you with the history of amenorrhea. The patient has impaired sense of smell with hormonal disorder that delay or prevent puberty. It is genetic disorder that can be X-linked autosomal, inherited autosomal dominant. It is not very common. It is 1 in 48,000. The patient present to you is anosmia, and we can treat them with hormonal replacement therapy. This is due to inability to activate pulsatile gonadotrophin releasing hormone and due to impaired olfactory function. As we talked earlier also, we need an intact hypothalamic pituitary ovarian axis. If there is any defect, any level, it will give the primary amenorrhea. Either from the hypothalamus, the stimulus is not going to pituitary, or from pituitary, it is not affecting the ovary. Now, the common causes for hypogonadotrophic hypogonadism. In this, hypothalamus and pituitary gland do not produce hormone that signal the ovaries to produce sex hormone. Either it is idiopathic or there may be some tumor, crangiopharyngioma, compression of the hypothalamus, diseased gonadotrophin releasing hormone secretion, interrupted portal flow of gonadotrophin releasing hormone in pituitary stalk. Kalman syndrome I already explained to you. Weight related. Nowadays, when they will lose their weight extremely or they will gain weight, it will lead to amenorrhea. Regular menses will come back if they will gain weight. Exercise also cause the amenorrhea, not the normal exercise. If they will do strenuous exercises, hyperprolactinemia, in this there is primary amenorrhea, but breast development and uterus is present. Overall, there is reduced secretion of FSH-LH. As a result of this, failure of follicular growth and estradiol production of the ovary, hypoestrogenous status, no organic lesion in the hypothalamus or pituitary, or the situation is idiopathic. In this, you will not find any lesion or any reason, like if they are going for extreme weight loss or doing exercise to weight loss. As I told you, there are causes of chromosomal anomalies. In that, the commonest is Turner syndrome. In this, there is one X chromosome is missing. Either it is XO or XX. 2/3 of one chromosome and the rest has structural abnormality in one chromosome or display mosaicism. 25% have normal chromosome. They have pure gonadal dysgenesis and they have streak ovaries. 50% Turner syndrome has ovarian dysgenesis. How to diagnose before birth? When you are doing NIPT, free cell DNA screening, you can find out this. When you do a scan, there are cardiac abnormalities, aortic valve abnormality, there is bicuspid abnormalities, abnormal kidney. Sometimes there is large collection of fluid on the back of the neck known as cystic hygroma. When the baby will born, you can make out from the picture, they are having webbed neck, their heart has coarctation of aorta, broad chest, widely spaced nipple, cubitus valgus. They have a pigmented nevi and streak ovaries. There may be peripheral edema at birth. Now, we have all the causes of primary amenorrhea, how to do and how to manage these cases, how to do the diagnosis. In that case, you have to take a proper history. In this history, you have to ask the patient or the mother, if she is accompanied the patient, about her growth. Is she taking any drugs? Is she trying to reduce the weight? Is her weight is suddenly increased? What is her habits? Is she psychologically disturbed or she is using any drugs? There is any sign of hyperandrogenism, hirsutism, virilization, or there is any acanthosis nigrans. When you do the examination, mother should be present. Check for secondary sexual character, breast development, and external genitalia. After taking the history and examination, always exclude the pregnancy. Do a scan to find out whether the uterus is present or not. Now, we will divide the diagnosis in breast present, uterus present. It means this amenorrhea, you do the workup like secondary amenorrhea. If the breast is absent and uterus is present, then you go for lab test for FSH. This FSH, either it is high. If it is high, it means it is hypergonadotrophic hypogonadism, gonadal failure, because the estrogen is low, for example, Turner syndrome. If it is normal or it is low. If it is low, there may be some pituitary or hypothalamic issue that you should do a confirmatory GnRH test. After doing the GnRH test, if your FSH levels are normal, it means the cause is in hypothalamus. If the breast is present but uterus is absent, you ask for karyotyping. There may be androgen insensitivity syndrome or XX Mullerian agenesis or MRKH syndrome. So all these things you have to inquire that this patient also include that if they will tell any history of infections, mumps that can lead to amenorrhea. Now, you have to check all these things, and if it is the BMI is from the beginning. Now you have to check. We checked it: breast present, uterus present, breast absent, uterus present, breast present, uterus absent. The last one is both breasts are absent and uterus is absent. In that case, there is some enzyme deficiency, and it is a very rare condition. 17 to 20 dismolase deficiency or 17 alpha hydroxylase deficiency, 46 XYA gonadism. This is the overall summary for the investigation. As I told you, if breasts are developed or breasts are not developed, you can go through this. Now, we have done the investigation. We are now at the level that we can judge what is the reason of amenorrhea. Now we have to treat according to the cause. Correct the underlying cause. Estrogen replacement therapy if there is any tumor, surgical resection, radiotherapy or drug therapy, or surgical correction of genital tract. Now we have done the investigation, we know the causes. Now we have to treat the patient. You treat the patient according to the cause. Correct the surgical if it is needed, if there is any genital tract problem. If patient is losing too much weight or doing exercise, explain to them, give them psychological support. If the reason is hyperprolactinemia, treat them. If there is any pituitary cause, you have to treat the cause, and the patient will regain their amenorrhea and she will have menses, and there will be cure for that. But you have to look for the cause always and treat the cause accordingly. All these patients, because they are young, they are disturbed, they need a very proper psychological support. To give them the psychological support slowly and gradually. You cannot treat the amenorrhea within a day. Give them very nice psychological support by a psychologist, by the mother, by friends, and after talking to the patient. Don't forget to subscribe my channel, and any topic you want, please write down in the comment box and you will see in my next video. Thank you so much.